So I have some questions for this group because I don't know who I'm talking to. Let's just get some show of hand things. How many people here are veterans? All right, lots of vets. How many people here are veterans' family members? All right. Advocates, caregivers, anything like that? Okay. Treatment providers. Well, we're underrepresented. Other groups, I think a couple people didn't put their hands up. What are you?
I'm part of the JVST team, DBOT.
Okay, and
I do budget for WDDA.
okay, and there was somebody else I thought.
I'm a program coordinator for Veterans Court of Hart County.
Cool.
Veteran Service Officer for the NUCSAC track.
We love VSOs. Yeah, hopefully I'll remember to mention we have kind of a special program in new family counseling for VSOs, and it's a really cool resource we have. So another show of hands. How many people here have ever worked with an individual who experienced a brain injury? All right. How many of you know somebody who's experienced a brain injury besides clients and patients? All right. So what I would like to do today is kind of a, like I said, brief exploration. I'm going to cover things that a lot of people here probably know. Seems like we need to be talking about what are the different types of TBI, what are the definitions and things like that. But my learning objectives, I'd like to define and differentiate between the different types of traumatic brain injury, some of their causes, some of the clinical presentations. I suspect I'll spend way less time on treatment things here than just talking about kind of the nuts and bolts of traumatic brain injury. To me, that's because when I start to dip into treatment, I realize it goes a bazillion ways because there's a bazillion clients, and there's nothing you can say that pertains to everybody. So other than nothing pertains to everybody. I would like to work on some of the evidence-based information regarding outcome expectations for traumatic brain injury and treatment considerations, even though we won't get into treatment in any depth. I would like to talk about managing risk factors that are modifiable. We can do something about it. And that is going to include at least some focus on self-management following traumatic brain injury. Identify ways to work with individuals appropriately who've experienced TBI. And then finally, and fairly briefly anyways, recognize when a referral to a specialist is indicated. Frankly, I think quite often the referrals I get that involve traumatic brain injury come from specialists. There are already specialists, neurologists, for example, involved. So a little quiz here. Jot it down if you want to, do it in your head. True, false for 4 different questions. And let's see where we get when we finish this first part. True or false, self-reported current symptoms are important for diagnosing traumatic brain injury. And think of your answer, keep it to yourself right now. Number 2, the most common cause for traumatic brain injury is car accidents. True or false? Number 3, concussion and mild traumatic brain injury, MTBI, generally are interchangeable terms. And number 4, mild traumatic brain injury symptoms mostly resolve in weeks. So some definitions. Traumatic brain injury is an acquired injury. It's not something you're born with. It's caused by some sort of external event or a force. These are not brain injuries caused by tumors, infections, lack of oxygen, bleeding inside the brain, although a traumatic brain injury can involve brain bleeds. An example that's very relevant to all of us as vets is the classic form of traumatic brain injury from Southwest Asia, an IED impact. So that starts with an incredibly powerful pulse of hot compressed gas that produces a shock wave that spreads out at way more than the speed of sound. When that shock wave gets to things, it disturbs things. So when it goes through somebody's body, it makes things move around, causes damage. And after the blast wave, there's a suction, kind of, not quite a vacuum, but a low pressure wave that comes after the blast wave. that creates a suction force that can do additional tearing and shearing and displacing and things like that. So the blast wave itself is not the only cause of injury. There can be a vacuum wave after it. And we'll talk in a minute about other types of injuries that come from, that are TBI related, that come from that kind of event. One of the things about definitions of traumatic brain injury is that there are various definitions, and this causes trouble. We're going to see some statistics, kind of epidemiological information, where there's quite a bit of variation, and if you look at the research, you find that there are huge differences in what they say various percentages are. Part of that is because of these definitions. They're not the same. This is just three. The CDC, okay, it's a disruption in brain function that's caused by a bump or a blow or a jolt or penetrating brain injury. Notice the VA definition is really brief. An injury to the head that affects the way the brain works. Pretty broad. And DSM-5, the Diagnostic and Statistical Manual for the Psychiatric Disorders, 5th edition. This is a pretty long definition. Brain trauma with specific characteristics, and it includes at least one of loss of consciousness, post-traumatic amnesia, memory loss after the trauma, disorientation and confusion, or in some cases, severe cases, neurological signs. For example, bad neuroimaging, CT scans or MRIs that don't look good, onsets of seizures or worsening of seizures, visual field cuts. What's that? Partial blindness, right? Anosmia. I'm not sure I can pronounce that right. What's that one? It's got the word in it, nose. It's a loss of smell. Okay. Hemiparesis, that's like paralysis or a lack of function on one side of the body, maybe differential to the other side of the body. Notice the DSM-5 diagnosis is a pretty complete diagnosis. So here's the classic famous example of a penetrating traumatic brain injury. That's Phineas Gage. He lived in the early mid-1800s, and he was a railroad worker. And that thing that he's holding in his hand is what went through his left frontal lobe. All the pictures I could find that showed more about the injury are so gross that I couldn't handle showing them to a lot of people. They're really bad. What he was doing was using a rod like that to tamp explosives in a hole that had been drilled, and the explosives went off, and the rod went in here and came out here. You can see his left eye is gone. He lived. The literature on him is varied. You look in different places, you get really different information. But apparently he lived, and he suffered pretty big personality changes. And you'll notice in that picture, he's standing up and holding that rod. Physically, he had quite a bit of functioning. Apparently the personality changes kind of went away. And 12 years after the injury is when he died, so he survived 12 years. And I found a really interesting account that attributed his improved personality situation to getting a job operating some sort of vehicle in Chile, and it was such a structured job that he got better and his personality improved. Interesting story. The other thing up in that is the coup contre coup injury. It's really common, and this picture shows your head hitting something and causing a traumatic brain injury. That can also happen as a result of some other kind of like a blast wave, the shock wave going through your head. And your brain is floating around in this juice inside your skull. And if you stop, it's kind of a rapid deceleration injury. Your brain bounces off the front of the skull inside and then rebounds against the back of the skull. So traumatic brain injuries physically are often very complicated, neurologically often very complicated. They can happen in several different places. Some other aspects of injuries, and this is very relevant to things like IEDs. People talk about primary, secondary, tertiary, quaternary, and then one I've never heard before, quinary. That means the fifth one. Primary traumatic brain injuries are the injuries from the blast wave impacting the body surface of the brain. Secondary traumatic brain injuries are injuries from projectiles like bomb fragments, flying debris. Those are usually penetrating injuries. Tertiary is where you're thrown into something. So that picture with the coup counter coup could very well be a tertiary traumatic brain injury. Quaternary is harm caused by inhalation of like toxic gases and things like that, or blood loss. So it's coming down the line a little ways. And quintary is injuries from additives, so biological agents, radioactivity, things like that. We tend to be interested mostly in primary, secondary, and tertiary. That's what we're going to see the most of. So what causes these? That was the first question. By far the most common cause for TBI is falls. The second category there is other, so there's a variety of stuff. Being hit by a blunt object is the third one, motor vehicle accidents and assaults in that order. In veterans on active duty, the most common cause for traumatic brain injury is an IED or similar blast. So veterans are different in that sense. And anytime I do a presentation, I have to amuse myself. Most of my joke slides are about dogs. And as a psychologist in the state of Washington, and this is true of a lot of mental health professionals, I can sign letters for emotional support animals. It's amazing how often I do that. Somebody asks me, I'll say, of course I will. I mean, why wouldn't I? Epidemiology. In the United States, about 3 million traumatic brain injuries a year. In veterans, 400,000 traumatic brain injuries from the year 2000 to the year 2020, so 20 years. 75% of the traumatic brain injuries are mild traumatic brain injuries, and we're going to talk about what that is in a few minutes. But it's important to keep track of. We mostly see mild traumatic brain injuries. And another aspect of that, because of what mild traumatic brain injuries are, they quite often aren't detected. So the statistics are probably not very good. More than 55,000 deaths, men twice as often as women, and 280,000 hospitalizations, men 3 times as often with women, with the highest rates of death or hospitalizations for those over 75. Now, why would that be?
Balance.
Say it again?
Balance.
And so what does that do?
Makes you fall down and have a TBI.
You fall and you have a TBI, exactly. That's what we were looking at. So notice that this little slide says that about 50% are caused by falls. And I just said before it was 40.5%. There's an example of how when you look into the numbers and you look at the research, it varies a lot. So categories of traumatic brain injury: mild, medium, and severe. Okay. The category, and I'll call this a diagnosis because I'm a healthcare provider, it's based on the symptoms or the status of what's happening shortly after the injury or at the injury, not later. And there are lots of things that happen long after the injury, but to be mild, medium, or severe, mild, moderate, or severe, that's determined very quickly. Quite often by emergency medical personnel at the scene of an accident or a fall. More severe injuries tend to result in worse long-term outcomes, and we're going to see examples of that. By the way, anybody have a question, just interrupt me. I mean,
Just a comment, as an EMT, we realize that the reason many times hospitals keep someone for 24-hour observation after a vehicle or possible head injury is because the severity, that's usually the curve of severity from brain bleed, is if anything's going to show up, it'll show up in that 24-hour period, and if not, you're good. Yeah, and that's also why if your family member gets a head injury, your child gets a concussion, they'll say, don't let them sleep more than, a couple hours at a time. They wake them up.
yes, thank you. Thank you. Good comment. And notice he said possible head injury, I mean, right away, we've got this kind of, well, is there one or not? And that word concussion, I think we've got it in here somewhere. But concussion and mild traumatic brain injury are considered to be the same thing. And so, people ask each other, do you have a concussion? The answer is, I don't know. Maybe you should go to the doctor. Oh, I feel okay. That's probably a TBI. That's not going to get into the statistics. So I know this is kind of a busy slide, but we'll go through it pretty quickly. Mild, medium, and severe. And mild, we might use the word concussion for that. They're interchangeable. And they are differentiated along the lines of those 5 different things. Although notice neuroimaging, we'll dismiss that one right away, because they don't really differ on that. You may or may not see things in the brain on a scan. You might not. So there's 4 that are really important. These all have to do with consciousness, even though I know the first one is loss of consciousness. So mild traumatic brain injury is no consciousness at all up to about a half an hour. So fairly brief. And I talk to people who will say things like, I don't know if I lost consciousness, okay? And they may not remember, of course, there is post-traumatic amnesia involved, but 0 loss of consciousness can still result in a TBI. Medium traumatic brain injury is 30 minutes to 24 hours, and severe more than 24 hours. Alteration of consciousness. Lots of times clients will say, I felt like I had my bell rung. That's alteration of consciousness, like for a little while. Mild, immediate, it happened right then, up to a day later. And that's one reason why people are kept in the ER, or family members are asked to kind of watch them, because it may be as much as a day before they get that kind of alteration. Medium, more than 24 hours, and severe, also more than 24 hours. Post-traumatic amnesia is forgetfulness that starts at the time of the trauma. So it didn't exist before the trauma, but after the trauma, the client or the patient will complain about memory. We're going to see that that's not assessed very formally sometimes. But for mild TBI, we're talking none at all to a day. Not much more than a day would ever be mild. 1 day to 7 days is medium, and more than 7 days is mild. Okay, and we'll talk about the Glasgow Coma Scale in just a minute. But look at the difference there between mild traumatic brain injury and severe. You've got somebody who may not have been unconscious at all, compared to somebody who's been out for more than a day. That's a big difference. Post-traumatic amnesia from none at all to for more than a week, this person is not able to keep their memory together. They're complaining about having memory effects. Big difference. Everybody loves the Glasgow Coma Scale, so we have to talk about it a little bit. This has to do with how you rate consciousness. And my EMT friend here probably is very familiar with this scale, because quite often it's done by emergency medical personnel when they first show up. And later on, it may not be as useful, but if it is necessary later on, we're almost always talking about a much more severe traumatic brain injury. So we can pull this apart pretty quickly. The eyes thing has to do with the person's use of their eyes. And it's not vision so much as the use of the eyes. It's a real good stand-in for how aware or alert the person is. And you can think about it as if you're asleep and you wake up and your eyes open up, that's not a coma. If you're asleep and your eyes don't open up, that's a coma, okay? So the scores there can go from 4, which is spontaneous, a person will just open their eyes up, down to the very bottom, none, that's the coma, they don't open their eyes. And we don't have to get into too much detail, but the score of 3 is when you go, Clark, are you all right? And I open my eyes. And pressure, usually when they say pressure, they mean something like a pinch. No permanent tissue damage, please, but just a pinch. What do you do when you administer that?
Well, we would do eyebrows. We would
Okay.
rub the eyebrow, literally, or we would thump the sternum.
Okay.
Initially, I noticed lately EMTs in Spokane kicking the feet. you know, so that the foot flexes back, because they don't want to touch anybody nowadays.
Oh, that's good. When I did EMT training, they talked about a sternum rub,
Yes.
like with your knuckles. So that, I mean, you're not causing damage, but it's pretty hard to ignore. Okay. The verbal, this represents kind of general brain functioning, thinking, memory, concentration, attention span. A good way to measure that is a person's verbal responses. So a +5 is somebody who's oriented. That person knows who they are, they know where they are, they know when they are, they know what's going on, and they can talk about it. They tell you, you know, what happened. They tell you that they want Aunt Sally to be told. They're obviously orientated. A lower score, 4, is when somebody's confused. They talk, they make sense, but it's not that much sense. It's kind of confusing. The words go together, but they're confused. A +3 is when the person can form words and it makes no sense. Psychologists might call that a word salad. And it's almost impossible to demonstrate because our brains won't do it when they're intact. But a word salad is just words that they don't have any relationship. A +2 here is a person can make sounds, but not words. And then the bottom score of just 1 is this person is not verbalizing or making noises. I'm not sure how groans of pain fit into that. I'm not sure. The last one there, motor, and we won't spend much time on this. This is really kind of a neurological subtlety, I think, but we're talking about brain communications with a person's muscles. So a high score, when a person is intact, you give them a command, they obey. Clark, raise your right arm. They do it, okay? And then going down 5, 4, 3, 2, 1 is worse and worse communication between the brain and motor movements until there really isn't any. So if you did like a sternum rub or that eyebrow thing, you don't get any muscle response at all. At a level above that, and I don't know the neurological differences between these, but sometimes you have an extension response, sometimes you have a flexion response. Those are different neurologically. So if we just go back for a second here, that Glasgow Coma scale for mild of 13 to 15, notice 15 is right up there at the top. That's a completely, totally intact person in terms of the coma scale. And 13 is not down very far. Okay? Medium is a significant drop, 9 to 12. And again, look at this one here. To get 9 to 12, you're kind of in the middle of that table somewhere. And the last one, the severe, is less than 9. And to be less than 9 on this table, this person's got some pretty significant challenges to their consciousness. A little bit about traumatic brain injury impact on functioning. I saw somebody nodding a minute ago when I said every injury is different and it has a big impact on how you do treatment. Every brain injury is different and it's greatly affected by a lot of different factors. Some of these are pretty obvious. The severity of the injury is going to make a really big difference. But remember Mr. Gage, that was a pretty serious injury, and there's that picture of him standing there holding that rod. He was obviously fairly intact at one point. The location, the injury matters, particularly in terms of what's going to be affected. You might get really different effects on memory from an injury here than from here. Different parts of the brain are doing different things. And the mechanism, of course, a shock wave through the brain causing significant injury. A scan might show us some of what's going on there. Might not be very visible otherwise. A penetrating wound is going to be pretty alarming and maybe a lot more damaging. Another thing in terms of differences between brain injuries is what was the person's pre-injury functioning? And that includes their psychiatric functioning. Also, does this person have compensatory strategies? We will see that one of the risk factors for suffering a traumatic brain injury is having had a traumatic brain injury in the past. Go ahead.
I was just going to say, my last 2 deployments, we had to take a test prior to deployment, and it was when I was with the medical brigade, they were pioneering a lot of the treatment for TBI in country. But I had a soldier that ended up having a rollover, had a mild TBI. He had to take that test again when he was, during the treatment to see the severity. So I forgot what the test was, but there was a lot of questions. I guess, I don't know. Most of us probably just took it thinking, okay, whatever. But yeah, he had to take it again after the TBI happened. And I guess that's how they get a treatment plan.
Yeah, one thing I'll comment on at the end of this presentation is that sometimes there's not a lot of reason to do a lot of assessments, particularly with a mild traumatic brain injury. If you're going to recover pretty quickly, there may not even be time for very much assessment. But one of the reasons, and you just pointed it out, if you want to know how much dysfunction there is, it's really good to know what the pre-injury functional level was. Another question.
Well, I was just trying to piggyback on him because, trying to see what time frame that was when he said they had to go do a test. Because for me, I'm speaking on my behalf. I'm a Purple Heart recipient. I've been blown up like 5 times overseas in Iraq, and I'm a currently patient of TBI. So I'm here just to learn about this because I know the military don't teach a lot about it and whatever it is, and VA. So I'm here to learn about it myself and as a VSO for my clients. So I just, when I went through and had my episodes with this and from IEDs, I didn't get none of that, what he talked about, So it was just like, oh, you're good? Go back out there again.
I actually went to a WDVA VA conference, it was probably 15 years ago at SeaTac, where I saw a very interesting presentation where they looked at some fairly complicated cognitive functioning tests for people that had mild TBIs and had no apparent dysfunction, but they could see dysfunction in the testing. And there were some effects on concentration and memory. The kind of tests I do as a psychologist, and I know they can be pretty sensitive, and it showed up on those tests. Another question?
Yeah, in regards to Mr. Gage's case study, you said he died 12 years later. Was
Yes.
that from the brain injury, or what did he die from?
I don't know. And I think that may be because it's hard to figure out when you look at his history. So, I mean, he died in something like 1888 or something. I suspect the records from them aren't very good.
Just a comment related to knowing at the point of the injury, fall, whatever, whether it's really serious. Just a couple days ago, they released the information that Richard Simmons actually died as a result of a fall, which was not known. Richard Simmons, the exercise guru, had fallen, gone to bed, tried to sleep it off, and died.
Yeah.
So,
I want to mention one thing about the pre-existing compared to the new norm is it's very important for those in close relationship, like family members or significant others, when there's been an injury, to accompany that person to the exam in the emergency room and be very assertive about saying, no, this is not normal for them. Especially with older people, they'll maybe say, well, you're confused. All older people, no, this person is like right on, like my father. In his case, they were like, well, and I said, no, this guy was a rocket scientist. I'm telling you, this is not normal for him. Because many times, the overworked emergency professionals will ignore issues like yes, but before. And so it's very important to know how the person was functioning.
Yeah, and I'm hoping one thing we'll get to is exactly that sort of thing is TBI has an incredible effect on interacting with healthcare.
Oh, yeah.
And you're right, older people are never confused. I know.
But they're good at lying and hiding it in the ER.
Well, that's because we have compensatory strategies. Okay, so they include lying and hiding it.
Sir, I just wanted to caveat on what he said. It wasn't until 2010 that they really started developing the TBI treatment stuff in the military. So unfortunately for us, it also started before 2010. We didn't take no test, but it was after that we started taking that cognitive test before deployment. And then they got the treatment center started in 2010. I think they partnered with the NFL to study all that stuff too.
So a couple other things in terms of the TBI impact on functioning that are important. Social supports, we've been hearing that. And secondary gain, and we all hate to think about secondary gain, but there are reasons for people to be screwed up. And sometimes you get benefits. So that makes things more complicated. I've got long lists here of the common symptoms of brain injury, and I'm not going to go into it in depth. Pardon me, my throat's getting weird. But there are a lot of symptoms. I like to think of a whole class of the symptoms. This is the psychologist talking, that usually show up as some kind of antsy, anger, irritated sort of situation, as the result of something that is obviously true, and it's not that complicated. A lot of what our brain does is inhibitory. It keeps a lid on things. And so when you damage the brain, some of that gets released. And so a really common symptom with traumatic brain injury is difficulty managing anger and irritation and volatility and those kinds of things. So there are a lot of symptoms that are kind of related to that. Brain inhibition is inhibited, it's damaged. So the brain is not controlling things as very well. And you see lots of difficulties. And of course, this flows into all kinds of situations. You're trying to get medical care, you talk to a provider that doesn't want to listen to you, and you get pissed off. And you may not get much care after that, but it does happen.
It's a cough drop. Just wondered if you were interested.
What is that?
Cough drop.
Ah,
If you're interested, let me know. It's here.
okay. Thank you. There's a lot of other cognitive symptoms that are common among various levels of TBI, but these are all memory, attention, concentration. Some of them are very interesting. It's really common for traumatic brain injury to result in a sensitivity to sound and light, okay, which is a cognitive function here. People have trouble making decisions. Like I said, they have trouble inhibiting behavior. It may not be anger, it might be impulsivity and things like that.
I had a quick question, if I may. With TBI, how does it affect others differently if they have neurological disabilities such as dyslexia?
Good question. A lot of that is related to maybe the complexity that's immediately implied with that question. I mean, if you already have neurological difficulties, I would like to think about it as maybe you already have some traumatic brain injury and you get more traumatic brain injury. It seems like that's going to lead to a bad place most of the time. Now, in looking at literature, I discovered that's not always what people think. I mean, people will say, if you've had like a mild traumatic brain injury or moderate, and somebody's worked with you, so you have a lot of those compensatory strategies, that you're ready to deal with another traumatic brain injury. And sometimes people do better on a second brain injury. They've got social networks in place already and things like that. Let me see where I'm in my own notes here.
Speaking of some of the symptoms afterwards, I would say I've had a very positive experience after having a pretty significant brain injury, in that I used to have chronic and debilitating anxiety and panic attacks. And after this brain injury, that almost entirely went away. It's been about 4 years now, and it is kind of slowly creeping back in, but it was a remarkable shift, along with other symptoms, not particularly as great, but that one actually was kind of pleasant to experience for a while.
Yeah, thank you for that. So the majority of traumatic brain injuries include a very wide range of effects and symptoms, and they can range from that, I had my bell rung, temporarily dazed with no symptoms even minutes later, but no more than hours later, to maybe 30 minutes of loss of consciousness or maybe obvious damage seen through neuroimaging. So there's a really wide range of effects here. There's kind of a list of some of the things I was just talking about in terms of symptoms. There can be lots of symptoms, including things like sleep. And a lot of these will interact with each other. Hopefully I'll have a minute before we get too far into this to talk about the interaction between anxiety and sleep. You work with clients, you quickly discover that sleep disruption and anxiety are like this. You can't really pull them apart very well. So the typical course of a mild traumatic brain injury is got two different branches. The vast majority of people get an acute recovery where in 3 months it's really difficult to tell if anything has happened to them. And in fact, the average recovery is 1 to 2 weeks, and quite often maybe towards the low end of that. And again, remember, this is a concussion. A lot of people will never be diagnosed as having had a mild brain injury. They probably recovered very quickly. And remember that with this mild traumatic brain injury in that slide that defined it, the post-traumatic anxiety was probably less than a day, and not very long. There is another version here, chronic recovery, and it's really hard to tell how many people this represents. But these are cognitive difficulties that last more than 3 months. Persistent post-concussive syndromes, I'll just call that a syndrome from now on. But typically with headache, dizziness, concentration, and memory deficits that last more than 3 months. And the average that I see kind of quoted in the literature is about 15%. But the literature has a range that goes from probably less than 10% to more than 80%. Why? Why is there such a wide range when we think we know about traumatic brain injury, but some people have mild traumatic brain injury with 3 months of problems, and it's between 10% and 80% of the people?
The symptoms may not be associated with that traumatic brain injury.
Exactly, that's part of it. Another thing, remember, we've talked about this already, the TBI may not be reported, okay? And here's a good slide for you. This one's a little busy too. You really just need to notice that there's 3 different kind of diagnostic typologies there. And each one has a list of checks as to what fits in the definitions in those typologies. And notice they are not the same. So there are differences in definitions and diagnoses depending on what typology you're looking at. And okay, I'm a psychologist. DSM-5 is the Diagnostic and Statistical Manual for the Psychiatric Disorders, 5th edition. Well, that's what I'm going to be looking at. ICD-10 is more of a medical one. So a medical provider might look at that one. And the checks don't completely overlap. They're quite different types of symptoms that are looked at. And somebody's going to ask me, what are the A's and the B's? Nobody's going to ask me? Okay. I'll tell you anyways. The A's are self-reported data. So in ICD-10, self-reported concentration problems and memory deficits meets the criteria. In DSM-4 and 5, it has to be through some kind of assessment. Okay, those are quite different. I might give somebody a WAIS-4 and do some relatively robust memory assessments or concentration assessments as part of that test. That is not self-report. I mean, that's a way more robust measurement. One thing that happens with all people and all patients, and particularly with people who have traumatic brain injury, and probably even more important mild traumatic brain injury, there are these psychological processes that go on with folks. I call them attributions and expectations. These are pretty obvious once we talk about them. When you have a symptom, so almost all conditions have a huge overlap in symptoms. It's probably hard to tell what illness somebody has if you just look at the list of symptoms. So if you have a symptom of anything, oh, my memory's no good today. Oh, I had a mild traumatic brain injury. That's an attributional process, okay? And that happens a lot with people. There's also an expectation part of that. When you hear the term traumatic brain injury, you immediately have a set of expectations of what that means in terms of what it does to the person. Memory problems and things like that. And of course, that's true for the people that are victims of traumatic brain injury. Second one up there, the good old days. Again, this is something we all do. I remember the good old days when I was 40 and I could slam dunk a basketball. Not. Okay, we all think about being more functional in the past than we are now. And so when you've had a mild traumatic brain injury and you think about how functional you used to be, there's kind of a distortion there in how you attribute your symptoms and the causes of the symptoms and what you expect to happen. Okay? And that syndrome thing, the prevalence of the symptoms with that syndrome is pretty wide. So, and I know I wrote that in a funny way, but depression, anxiety, pain, insomnia, are those symptoms only of traumatic brain injury? Of course not. Okay, so, those are very prevalent symptoms of all kinds of things. And we already talked about how people attribute the symptoms to a traumatic brain injury. Providers see a lot more complication in terms of where symptoms come from. So providers that are providing care, whether it's a medical doctor or a psychologist or anybody, is going to have a different perspective on what's going on than the person who's a victim of a traumatic brain injury. Part of that's the attributional thing. I feel bad today, it's because I got a TBI, and part of it's the expectations. I've had a TBI, so of course my memory is going to be screwed up. And providers may see it much more in terms of, well, the damage was right here, okay, and have a very specific idea of what that means rather than just kind of general symptomatic problems. All right, break time. Remember, I like dogs. My wife is in the front row. Does this look like our house? She's nodding. And notice the dogs are all smiling. They love it.
My cat does the same thing. Underfoot.
I didn't bring any cat slides, sorry.
Oh, okay.
With what you've been discussing most recently in this group, I'm thinking about how we differentiate TBI from symptoms of PTSD when you've said that someone can have a TBI and might not necessarily show up on a scan. Can you talk a little bit about that?
Can you hold the question for a couple slides and we will talk about that, okay? Thank you for leading into a slide I'll get to in a few minutes. So we were talking mostly about mild traumatic brain injury. So here's moderate to severe. And remember, these are way less common. In some situations, you're more likely to see them. A lot of the mild TBI folks never know they've got a traumatic brain injury, but the course of recovery is quite different when we're talking moderate to severe traumatic brain injury. First of all, the increased severity leads to long-term symptoms and disabilities, and that can include things, inability to work, decreased functioning everywhere in your life, neurological problems. Moderate to severe traumatic brain injury leads to a longer recovery time. Probably the most rapid recoveries in the first 6 months, and most of the recovery is going to happen in the first year to 18 months. We're going to see a couple of curves here in a minute that shows that maybe it goes on for a really long time. But after 2 years, any improvement after that is probably because this person's learned how to cope with their traumatic brain injury. It's probably not caused by any healing. And it all depends on the individual. And remember, mild traumatic brain injury recovery mostly done in 3 months or less. Another thing to remember, this all depends on the individual thing. I know I mentioned secondary gain before. So, there are some secondary gain processes that go on. I see them in the VA all the time. I see them in clients who have been working with a VSO, and they've been working for 2 years to get a service-connected disability, and they get an award. And you've seen this, I'm sure. They have a rubber stamp on their head that says they're screwed up now, even though they've worked for 2 years to get it. And boy, there are a lot of things that go along with that in terms of depression and anxiety and feeling dysfunctional. This is still moderate or medium to severe traumatic brain injury. It's a much longer term process. We're talking pretty severe impacts, and there's some examples of that. A pretty high rate of unemployment, a pretty high rate of going to the hospital. A third of the people require assistance with normal daily stuff. Almost 30% are not satisfied with life. Almost 30% use drugs or abuse alcohol. 12% are in nursing homes or institutions. And when you think of somebody with a moderate to severe traumatic brain injury that's using illicit drugs and alcohol, I mean, what's the picture you get? This is not a good picture.
Question on that. Can you tell me, off the top of your head as a practitioner, what the incidence of illicit drug and use and alcohol abuse is in the general population? So it's a comparison to the 20.
I can't tell you. That's a good question, though.
Mm-hmm.
Talk to me afterwards, and I'll look it up, and I'll let you know.
Thank you.
And by the way, these numbers come from the CDC. And, I'm assuming or thinking they're probably using one of those ICD-10 types of diagnoses. And that, of course, is probably going to have an impact on this. And just to show that a different way, here's the mild, the moderate, and the severe TBI. Along the bottom, that scale is time. Going up and down is cognitive symptoms or dysfunction or functioning. The green line comes in at pre-injury functioning. It drops off at the injury. The yellow line is that quick recovery with mild TBI. And you'll notice that if you look kind of in the middle of that curve, it looks like it's somewhere around a month and a half or something like that. And at 3 months, it's pretty much back to where it started. The blue-purple line is moderate and the red line is severe. And so you can see these are ones that recover way more slowly, and they're still going up after a year. Looks like the severe may have plateaued. Looks like the moderate may still be going up. And remember, the moderate or medium TBI was somebody who had loss of consciousness for 24 hours or less. And the severe person was somebody with loss of consciousness for more than 24 hours. So some risk factors, and think of risk factors as, we primarily think about it as increasing the risk of a traumatic brain injury. I'd also like to think about this as increasing the likelihood of having symptoms after the TBI. So some of these are obvious. Alcohol and substance use. Somebody said something about balance as causing TBIs. Remember, the primary mechanism for TBI in the general population is falls. So if you're drinking and you're using, and the high-risk behavior, you're doing other things where falls might be involved, you would expect a higher incidence of TBI. Males more than females. This has a lot of relevance to the veteran population. Okay. Having a prior TBI. Why would having a prior traumatic brain injury increase your risk of having another one?
The injury is partly stacked, but it can also lead to things like imbalance or lack of coordination or a variety of other things that could lead you to fall or have some other kind of incident.
Yeah, lots of the symptoms would contribute to that, right?
Impulsivity. So as you go out and do more stupid stuff, you're going to get your head in a little bit more.
Yeah. Okay. Prior mental illness, and then a bunch of things, these aren't always explainable to me, but they're in the literature. Low socioeconomic status, and particularly low educational level, unemployment, homelessness, and domestic violence issues. All are risk factors for TBI. So what can we do to facilitate outcomes for moderate to severe TBI? Some of these, again, make a lot of sense. Access and use of effective health care. I've heard that mentioned already. Self-management, and I think about self-management as increasing independence in the client. So that can be things like day-to-day management of a chronic condition like traumatic brain injury over the course of the injury or any illness or injury. And when I say management, I mean lots of different things: medical, behavioral, emotional aspects of the condition. If you have a mild traumatic brain injury or worse, moderate to severe, and you're able to manage getting your medical care, you're going to be way ahead. And that's hard to do. We'll talk a little bit more about that. Same thing in terms of managing your behavior. Remember that disinhibiting kind of effect of impulsivity and anger and things like that. It may be hard to manage behaviors. And emotional aspects may include things like anxiety and depression and things like that. I think that kind of independence that self-management leads to, which is a real kernel important issue for people to deal with traumatic brain injury, involves things like problem solving and decision making and using resources and partnering with healthcare providers, that's some of you, and taking action instead of not taking action. One of the things I've noticed in my own practice that seems to happen a lot, a couple of the folks that work for me are really good at environmental interventions with veterans who need to take action and they don't. And so I'll read in a note about somebody was called at the VA and the veteran was handed the phone. That can be an incredibly helpful intervention. That kind of self-management and independence can also promote more effective engagement in therapeutic care. Those people that are working with my employees where they're helping them get a hold of a VSO or something like that. And Liz, you've got experience with that. It happens all the time between our offices. Those people are much better at dealing with whatever their problems are. Okay. Other things that are going to facilitate outcomes for moderate to severe traumatic brain injury is health-related behavior, physical activity, exercise, nutrition, sleep, sobriety. Some of those are obvious. Prevention of further traumatic brain injury, and again, some of this is managing those risk factors we looked at. Okay, I'm always concerned when I run into anybody that's had any kind of head injury, and they're, I ask them when was the last time they used marijuana. I ask that question every time, the first time I see somebody, and the classic joke answer is this.
Yeah.
And they'll say, I don't. And I'll say, well, when was the last time? And they'll say, yesterday afternoon. So, I'm thinking this person's still toxic. Okay. And community support. We'll talk some about community support. And this is mostly for moderate to severe traumatic brain injury. And again, the reason for it is quick recovery with a mild traumatic injury. It's not something that lasts very long for most people. So we talked about risk factors. We talked about promoting recovery. So here's some factors that are related to resiliency in traumatic brain injury. Things that help people deal with the symptoms and the problems that go along with the brain injury. The first one, task-oriented coping. That's an interesting term because to me it's a complicated combination of a lot of things like managing symptoms. But it includes stuff like, and think about this as task-oriented, wearing seatbelts and helmets, okay? Avoiding high-risk sports and drinking, okay? When you have conditions like headache, okay? So a task-oriented way to cope with a headache is to have an ice pack, to take medication, to get a massage, those kinds of things. Managing things like sleep hygiene, task-oriented coping with sleep problems might include managing your caffeine intake, having a consistent bedtime and wake-up time, avoiding that blue light on the cell phone or the laptop at night, using over-the-counter medications for sleep. Another place where task-oriented coping might be important is memory things. And of course, as we get older, we have issues with memory where we need to cope with that. So to use a smartphone as a way to keep track of stuff to help your memory. I've discovered with my cognitive behavioral therapy interventions with almost everybody, I love it when they're really used to using a a phone because they can keep track of their gratitude lists in their phone. Nobody wants to write on paper anymore, but to do it in a phone, people actually kind of like that. So, and again, with memory, things like alcohol use, prioritizing tasks and getting into a routine. And the last thing I'll talk about in terms of symptom management, which is task-oriented coping, is mood issues. Somebody's got a moderate traumatic brain injury and they're having a lot of impulsivity and anger problems. Does this sound almost kind of like normal for their condition? It may be, and it may be important to think about it in terms of, well, it makes sense that I have that problem, and maybe that would be that kind of acceptance might be the first step towards resolving it, kind of like a cognitive behavioral intervention where acceptance is important before you can do treatment and change. Some of the other resiliency factors are what the victim of the TBI thinks about in terms of what they have for social support. The perceived social support may be more important than the actual social support. So if a person sees they're being supported by their group, then they're probably going to do better. Probably it's good to not have a history of substance use before injury. It's better to have less anxiety. It's better to have less disability. It's better to have good satisfaction with life. I read a report, a research report that looked at moderate and severe traumatic brain injury patients, and the severe people reported on average significantly more satisfaction with life. And the way they explained that was these people were pretty screwed up, and when they did better, they definitely noticed it and felt good about it. And by the way, the task-oriented coping, kind of the opposite to that, the alternative, is kind of an emotional, sort of a talk therapy strategy, which can be useful, but telling me how you feel may not be as important as getting your doctor's appointment put in place. That it might work better to be task-oriented. It might be important to have decreased psychological distress, and it may be more important to make sure you've got a membership in the gym so you can get exercise. That might be more important. And another non-task oriented coping, which I wouldn't like, would be avoidance. Avoidance is not a very good coping strategy. So I think this dog has better task-oriented coping strategies. And I think the guy walking with the dog is going to have a lot of trouble putting coping strategies together. That person's life or that person's mind is full. Not mindful, but full.
You can tell this is a male. Because
you're right, it's a very short skirt, never mind.
No, you can tell it's a male because he doesn't know where his socks are.
And they're different colors.
Good one. All right, here's another little quiz for you. True or false? The most effective intervention for mild traumatic brain injury is psychoeducation. Number 2, true or false? Specialized assessment and comprehensive rehabilitation is required by patients with mild traumatic brain injury. Number 3, depression is the most likely mental health diagnosis associated with traumatic brain injury. Number 4, patients and providers almost always agree on the cause of chronic symptoms after mild traumatic brain injury. And number 5, somebody asked this question, PTSD is not related to TBI. True or false?
All false.
Clark?
I just have a question related to the previous screen when you said mindful, and the dog must be a good meditator because it's clear-minded. I was just wondering if you use mindfulness meditation as part of the rehabilitation process.
Yes, absolutely. That in my practice, that would be happening. Yes. Good question, good comment. So for all TBI, not moderate and severe, but mild, moderate, and severe, 50% of the people that have a traumatic brain injury have depression in the first year after that injury. Half. After 7 years, it's 2/3. So depression is really common with traumatic brain injury. I'm certainly willing to look at a lot of that depression as kind of a reactive depression, okay? And it's caused by things that are going along with the consequences of the brain injury, okay? Anxiety, the anxiety can be very complicated. Some of the anxiety is worrying about the impact of the traumatic brain injury on self and on family. That makes sense. And some of the anxiety might also be concerned specifically about cognitive changes, which quite often are going to seem like they're out of control. And there's probably a bidirectional effect there. Cognitive changes cause anxiety, anxiety causes cognitive changes. Also, looking at depression and probably the anxiety, we have to remember this is a traumatic brain injury. There are physical changes in the brain that could be very much related to things like depression. It could result in emotional responses to the injury that depend on where the injury was. Okay? And again, I'm willing to accept a reactive depression. You're depressed because of what's happened. It's not like it's an endogenous depression part of who you are. And PTSD may or may not be related to the traumatic brain injury. So it could very well be that the cause of the PTSD and the traumatic brain injury is exactly the same trauma. Okay, and so, I'm not sure about how I'm going to tease those apart. I think we got kind of two different conditions going on with lots of overlapping symptoms that are going to have to be dealt with both. And sometimes there's evidence of some kind of physiological process underlying both of those. If some parts of the brain are what's damaged, we know that certain parts of the brain are closely related to PTSD processes, the amygdala, the hippocampus, the prefrontal cortex. So if there is damage in those areas, then that traumatic brain injury could be very much related to the development or the expression or the process of PTSD. The question I heard is, kind of like, what do you do about that? Well, I think you're going to provide treatment for the PTSD, and the treatment for the traumatic brain injury in a lot of cases, remember we're talking probably about moderate and severe, not mild, because a mild's not going to last very long mostly. So a lot of that treatment is going to be supportive kinds of things, developing coping strategies. Some of those may not be very related directly to PTSD. In my practice, if somebody came in where I saw what looks like PTSD and looks like a traumatic brain injury, probably part of their course of treatment would be to put together a trauma narrative as part of the processing of the post-traumatic anxiety that goes along with the PTSD. And that may or may not have much to do with the TBI. Some things to think about in terms of care, and we're finally getting around to something that you brought up, my EMT friend. There are changes related to traumatic brain injury to things which are vitally important to getting medical care. And I'll use myself as an example. My wife up here, when I went to the doctor recently, said, make sure you wear your hearing aids. And then she said, and maybe I said it, if you don't wear your hearing aids, record it. And then, of course, if you don't have your glasses, you can't see anything, right? So the ability to function in areas like getting medical care, if you have deficits in hearing and vision and you don't do some of those task-oriented coping strategies, it's not going to work very well. It's not. Mobility and balance. Nobody but Keith and Elissa saw me walk in here today, but I have trouble with mobility and balance. The hotel, the convention center got me this really great stool. I'm taking it home with me. I could not stand at this podium anywhere near as long as I've been here today. I couldn't do it. And so you know, if you have trouble with mobility and balance, some of which could be directly caused by traumatic brain injury, imagine parking someplace in the classic healthcare garage and walking to your doctor's office. A lot of people won't do it, and it's going to be really hard. And the thing down at the bottom that I've labeled encumbrance of care, it's a great thing, and you were talking about it. Medical stuff is really complicated now. It's not just the medical information, it's making appointments, it's knowing who you're talking to, it's getting the message and knowing who has called and left the message. It's understanding what a provider tells you. It's really complicated. If you've got brain injury related challenges, that's going to be hard to deal with. Multiple appointments and scheduling difficulties. I'm sure I'm not the only person in this room that has trouble scheduling medical appointments. I think most of us do nowadays. And remember, providers see things differently than the traumatic brain injured patient. The provider is not going to see it the same way. It's not going to be a good old days attribution. It's going to be more along the lines of what's the damage, you know, and you know, can this person even report what the dysfunction is? May not be happening.
Clark?
Yes.
For that last slide, how often do you, as a counselor or psychologist, help your clients that can't help themselves? How often do you help them get other resources?
Whenever I can.
Okay.
Okay. We do a lot of environmental interventions. I come, that thing at the very beginning, faculty at UW, I was in the med school for a while in family medicine, and I learned kind of the medical model of when you get a referral from a primary care doctor, you send them a note back. So we coordinate really well in Colville, at least my office does. We talk to the docs. We're exchanging notes back and forth very often. I have no trouble calling up one of the local docs and trying to get somebody in, trying to push to get them in, you know, get them moved up a little bit, something like that. I think the local doctors rely on me for recommendations about psychiatric medications because we don't have a psychiatrist. The nearest psychiatric resources down here, and quite often it's the psychiatrist program that Providence runs, the training program. Okay, but you know, I get involved a lot with the medical care, and I think it's good. I mean, because if people are going to have trouble, whether it's because of TBI or something else, if they're going to have trouble making a medical appointment and they need a medical appointment, we should be helping them. Thank you for that question. So in helping people out, it's good to have targets that you can affect. Okay, so here are things that you can make a difference on. They're all kind of obvious. We don't need to talk about them very much. Diet, nutrition, physical activity and exercise, substance use, sleep management, pain management, medication use and side effects. I don't know if any other providers here talk to people that take their antidepressant when they feel like they need it. It's usually not a great idea to take that kind of medication. Other health conditions, education, including education of both the client and the support group. And that attributional expectation thing is a good thing to be talking about directly with people. You know, and most people are going to be willing to do what I did and admit that I couldn't slam dunk when I was 40. I think this is the last time you have to worry about a joke. Okay, so the most effective treatment for mild traumatic brain injury is psychoeducation. People who receive early, reassuring educational information report fewer problems with that syndrome that goes on for 3 months. And most people have no clue until they talk to somebody who knows something about traumatic brain injury that, in fact, a month or two from now, you're not even going to remember this happened to you. Most patients, or many anyways, do not receive adequate psychoeducation or any education following a concussion or a mild traumatic brain injury. And inaccurate information, like those expectation and attributional things, can lead to big problems. What does that mean for all of us? Well, the people in this room may be the primary source when we're talking to our clients or people that we are advocating for, we may be the primary source of education. Okay, and particularly around recovery expectations, where even if it's a severe traumatic brain injury, there's going to be a lot of recovery. Remember what Mr. Gage could do. It's really important to acknowledge the distress that people have about traumatic brain injury, particularly when they have some persistent symptoms that don't go away. It's really important to provide accurate information about that recovery process, particularly with mild traumatic brain injury, where lots of times you may not even see a client like that because they've already recovered. And it's also really important to target things that are modifiable, like I had in that other slide. Really important to track those kinds of things.
Excuse me. I was thinking about this in terms of a more severe brain injury as well, and having gone through that myself, I think of it kind of like if I was depressed about what I was going through, I wasn't really able to do anything about it. But as soon as I became interested, which I feel fortunate to have an interested mind and curiosity, but as long as I could maintain an interest and focus on what was happening and trying to do something that would improve my situation, it made it a lot easier to actually go through the process of having a brain injury.
That sounds like good treatment for depression.
Probably also, but the way that I realized how badly my brain was damaged was I looked at my clock and realized that I couldn't read it. I recognized that it was a clock face, but I couldn't comprehend what it was telling me, and which was a little bit frightening. I mean, I knew I had a brain injury because I had been unconscious for about 3 hours after a car accident and went through intensive treatment and a lot of surgeries and things, but it was that moment about 5 days into recovering that I realized, wow, I have no idea what this is. And it took me 6 months of setting the clock face on my phone with the 30-minute timer before the screen would black out, of just consciously several times a day, okay, I need to practice and figure out what time it is. And after 6 months, not that it took the half hour every time, but in the beginning, the phone would black out before I had actually figured out what time it was.
Did you have the advantage of having somewhere to give you the educational stuff I'm talking about?
I did not, no. And when I left the hospital, they said, well, you've had a concussion. I had actually scalped myself, so they had to sew my face back together. And I was unconscious for probably about 2.5 hours in the woods. My car went 180 feet off a cliff. But they kind of diminished it. They were working on physical injuries, and they just said, well, you know, get some rest, get some sleep, because you have had a brain injury, but you should be fine. And so there was a lot of things that came up that I had no idea were going to happen, like looking at the clock, going, what is that?
Wow.
Trying to talk and, you know, having the incidence of, you know, the wrong fishes come out. Like just randomly the wrong words would be in place of where they should have been. Just there was a lot of things, and some of it I didn't notice, would have to be pointed out by family, but I did have good family support, and that difference, and I recognized being interested prevented me from being depressed. And when I would start to get upset or depressed, I would have to refocus myself on, okay, let's find something that I can do about this, let's find something I can learn about this, and being interested in the process.
Thank you for sharing that with us. I'm not going to go into any detail here, but I think as treatment providers, we have ways to help people with these aspects of cognitive problems that come with traumatic brain injury. We have ways to help people with processing, with memory, and with attention. I think any kind of treatment, we have to be willing to adjust what we're doing in our counseling program. For example, we need to make sure we identify what are the personally meaningful and relevant values for that patient. Okay, we have to have structure in our treatment, which is going to help put things together that will work, have very clear and reasonable expectations, things like that. And with traumatic brain injury, particularly moderate and severe levels, it's really important to do the things that we all know to do, and it's easy to slip. Assessment for danger to self on an ongoing basis. Don't want suicides. Other things, and treatment providers should know what some of these things are. Motivational interviewing is a good way to approach traumatic brain injury because it's so collaborative and so non-confrontational. Coping with disability, helping people deal with disability. Environmental intervention, we've had a couple of examples out of my practice. Other people, I'm sure, have other examples like that. We talked about self-management and independence. I think, earlier in the presentation, I said something about assessment, and the gentleman here talked about assessment as a way to see where you get to as you're progressing through recovery. I think that when you know about symptoms early in recovery, that can help you as a treatment provider or a client to choose the right tools in treatment. And that early brief assessments can focus on areas that are really important like everyday living skills. But I think that comprehensive neuropsychological assessment, like I do in my practice, generally is not recommended early for most people because there's going to be a rapid recovery and you'll get stuck in where the person was in the past. They'll get better. That may not be something you need to do. Did I see a question in the back?
10 minutes.
Yeah. Should you refer somebody to a specialist? I said before, I think a lot of the referrals we get have a neurological component to begin with. Or the referral in my practice might come from a primary care provider or for the VA care in the community program where there's already some kind of neurological thing going on. But you should always consider a neurological referral. And in particular, that's true if symptoms are getting worse over time. What is the normal course? Things get better. If symptoms are getting worse, there's a problem. Are there problems with communications? And I mean that kind of conscious thing. I mean, is this person's communications okay? Are they getting worse? Is that a symptom that's getting worse? Are there complex medical issues? Something to pay attention to. Are there concerns about this person's ability to cope with their injury? If you're teaching them coping strategies, it looks like they're trying, it's not working, it may be a time to get a neurological consultation. Same thing with behavioral problems and more than minimal cognitive deficits. Okay, and I have one more slide. This is the payoff. And actually, Louis had me put one slide at the end, which I won't show you because it's one of those scam things. But here's the payoff for being here. Are you ready?
Hey,
I wish I had a couple of those.
Clark, when we do need to put the scan, that's how they get their continuing CEUs. Yeah, perfect. Thank you, sir.
One thing that I mentioned about all that you've talked about, from a service provider standpoint, is that a traumatic brain injury does not always have a blunt force trauma. It can be chemically induced. It can be bacterial, virologically induced. It could be cerebral accident. Lots of things can happen that actually cause organic changes in the brain that follow the same pathway. I just want to mention that. It doesn't necessarily something had to blow up or something hit you. It can be something that happens physiologically within the body.
Yes, and there was a time when I said, primary, secondary, tertiary, quaternary, and quintary.
Yeah.
I've got clients that I know that were underneath the black smoke clouds from the oil fields, and they didn't have any kind of physical damage to the brain, and they have service-connected disability percentages for traumatic brain injury. So the VA is fairly enlightened about that, I think.
Awesome.
I mean, the VA was the one that did that. Oh, and that reminds me, somebody said something, a service officer here. A model that Keith and I have talked about before, some years ago, Will Sampson. Does anybody here know Will Sampson?
I know Will.
You know Will Sampson. So he's, I think, a WDVA service officer, and he's like a step up, so he's got a little extra power. Years ago, he started coming into our office one day a month, and we've continued to do that. People can make an appointment through my office manager with a service officer in my office as part of their treatment, and that has worked wonderfully. Will does a great job. And talk about environmental interventions, he picks up the phone and solves the problem. He's good.
He's at the federal level now, the federal building downtown Spokane.
He's still in my office. I saw him this last week.
Hi. So, I'm not talking on a personal myself, but my husband. So he was not diagnosed with TBI till 18 years after he was in an IED incident. And it was a year before we got together that he was in the incident. And over the years, I noticed him getting angrier and more upset with stuff and not really knowing. It wasn't till his 18th year in the Navy that they decided in the Seabees to do a test, and that's when it was discovered. So I kept hearing 3 years, 5 years and stuff, but I mean, what about these long terms? Because I'm noticing some of the symptoms that were previously treated while we were still on active duty are starting to come back now that he hasn't been working for 3 years and he's been retired, and things are easily irritatable again. Me and the girls are irritating him all the time. We're just not, we don't understand anything and stuff, and he doesn't want to take the medicine properly. He doesn't want to do stuff, but he was so fast-paced while on active duty that it's like his mind never had the chance to really register the injuries. Because like I said, 18 years after was when it was diagnosed. And I just don't know what to do for him now because he's slowed down and things are kind of getting a little bit rough again, and he's not verbally or mentally abusive or physically, but he just is easy to irritate again and stuff. And now that we know what it's from, I just don't know how to help him.
Does he have a counseling or therapy relationship with anyone?
We live an hour away from anything.
You don't live farther than I do from anything.
Probably not, but getting him
No
to
way.
go in and agree to do anything is, it took me 3 years to get him enrolled with the VA.
Well, see if you can encourage him to come to see a therapist, a counselor, somebody that knows what we're talking about here.
Mhm.
And listen, I do live very close to the end of the earth north of here. The Canadian border,
Colville.
it's right over there.
Yeah.
And people can come in,
So the WDBA, that's kind of what our program, really supports, is kind of that referral, case referral, so connecting you with a lot of these resources and services. So I invite you all, I have our folders in the back, but I would like to connect with you and kind of help with some of those abilities. That's kind of what our program is designed to do, is those connection points. I don't know if that's helpful. They're in the back. Thank you, Holly, I appreciate that. Sorry, Clark.
Other questions? I appreciate such a wonderful audience, more people than I thought, and a whole bunch of people came up front. I love it. It's because I said something wrong with the microphone on.
No, for this one. It'll be on the last slide. Do you mind hitting the last slide for the QR code?
Oh.
Yeah, people are gonna.
There you go.
So can we give a big hand for Clark? This is awesome.